Hello and welcome to Live Healthy West Virginia, the podcast brought to you by WVU Medicine to help you live a better, healthier life in West Virginia and beyond. I'm your host, Mary Ravazio Menard. Illnesses and conditions affecting your child's kidneys, bladder, or reproductive health are not just the standard childhood illnesses. These conditions can affect your child's life into adulthood. So today, we're talking about pediatric urology from bedwetting to undescended testicles with Dr. Ahmed Ali, pediatric urologist at WVU Medicine Children's. The Pediatric Urology program at WVU Medicine Children's is the only pediatric urology practice in West Virginia, and it has been recognized nationally by U.S. News and World Report for the past 6 years. Welcome, Dr. Ali, to Live Healthy West Virginia.
Thank you so much. I appreciate the invitation. It's a pleasure to be here.
It's good to have you. So this is pretty impressive, being recognized, nationally for the last 6 years, and that we have the only pediatric urology program in the state. So I imagine you see it all. So tell me about what are the most common conditions you treat and see.
Thank you so much for mentioning that our program has been ranked for the past 6 years by the U.S. News and World Reports as one of the best pediatric urology programs in the country. And that is true. We see all the spectrum of pediatric urology. So we treat different conditions affecting kidneys, ureters, bladders, urethra, which is the P channel, as well as the reproductive system in children since they're born, or sometimes even before they're born, until they get to adulthood. So the spectrum of problems we see differs according to the age at which we see children. Mm-hmm. Some of the conditions are diagnosed even before the kids are born, like prenatal hydronephrosis. This is actually one of the commonest anomalies diagnosed on prenatal ultrasound.
Wow.
And it happens in 1 to 4% of all pregnant ladies. So it's very common. Nowadays, almost all pregnant ladies are getting prenatal ultrasounds, and we're able to diagnose these problems in that fashion. It's caused by a number of conditions, congenital anomalies affecting the urinary tract, and maybe we'll talk more about it later in the show.
Okay.
A lot of congenital anomalies are diagnosed once the kids are born, like undescended testicles, for example. External genital abnormalities are diagnosed at time of birth. And this is also one of the common conditions that we see in the field of pediatric urology.
So you cover a lot of ground.
Yes. As they get older, we see more conditions like urinary tract infections, for example. Mm-hmm. Incontinence problems in kids. Usually it's seen around the age of toilet training, 3, 4, 5 years of age. Mm-hmm. And then as they grow up, we start to see a different spectrum of problems, like kidney stones, more common to be seen in adolescents. Testicular torsion is also more common in the adolescent age group. And tumors also can happen in children. They typically happen before the age of 5 years. Another different category of kidney tumors happen in the adolescent age group.
Okay, so we're going to try to get to all these.
Okay, great.
So let's start first with one of the most common conditions, which is undescended testicles. Now, it's pretty common, but what exactly is this?
Okay. Undescended testicles is one of the common conditions we see in our practice. It affects about 1 to 3% of all newborn males. Testicles initially form inside the abdomen, and then they migrate to the scrotum or their final destination, typically before birth. And about 1 to 3%, this journey is not completed, so the testicle may stop at any location along this pathway, either inside the abdomen, the groin region, or in the upper scrotum. If the testis is not in the right location, it does not function in a normal way, and it does not grow in a normal way. So kids born with undescended testicle have to be treated in a proper time window to make sure their testicles grow in a normal way and function appropriately when they become adults.
What's that window?
The recommendations now is treat undescended testicles between the ages 6 months to 2 years.
Okay, so you've got to become aware of this pretty early.
The longer you wait, the more likely the testicle would have some kind of damage, and this may affect testicle function long term.
Are there any symptoms parents should look for?
Typically, this is diagnosed by the pediatricians or the neonatologist when the child is born. And typically, all pediatricians examine the external genitalia of all kids during their well-child visits. This is so we give these patients as referrals from the pediatricians. When they grow up and become older, some kids start feeling or observe, or families observe that they're not able to feel one or either testicles, and at that point it would come to our practice.
Okay, so how do you treat it?
Yeah, typically the recommendation is again to wait until the age of 6 months, because some of those kids who are not born with undescended testicles may have the testicle descend to the scrotum before the age of 6 months. The treatment is essentially surgical, so they need surgery to bring the testicle down, ensure the testicle grow in a normal way, and have a normal function long term. Based on the location of the testicle, surgery can be done by open surgery or laparoscopic surgery. Either ways, surgery has very good success rate and is able to preserve the testicles about 97 or 98% of the time.
Okay. So what about urinary tract infections? That's pretty common too. How can you tell if your child has a UTI?
Yes, urinary tract infection is one of the common conditions seen in the pediatric age group. The pattern of presentation differs according to the age of the patient. For nonverbal kids, like infants, of course, they cannot express their symptoms, but they typically present with high-grade fever, lethargy, they're not feeding, they're not playing, they're sleepy all the time. Sometimes they may present with blood in urine. Sometimes they may have other symptoms not related to the urinary tract. They may present with diarrhea or vomiting, etc. When they get older, we have two main categories of urinary tract infection: lower tract infection, which is basically bladder infection. Fortunately, this is more common. Kids with this kind of urinary tract infection, they may have pain when they urinate, they have urgency, frequency, they may have urinary incontinence or urine leakage after they became toilet trained, and they may also have some sort of blood in urine. The other category that I need to address is the upper urinary tract infection or kidney infection. This is more a serious infection. They typically present with high-grade fever, flank pain in older children, and kids are typically very sick with this kind of infection.
Okay, so how do you treat these different kinds of urinary tract infections?
Yeah, treatment is mainly using antibiotics. The duration and the choice of antibiotics differs according to the presentation, the type of infection, the organism that we are expecting. A lot of these infections can be treated as outpatient, meaning being treated at home. When kids are really sick, or when very young, or like in infants or so, they're not feeding very well, sometimes they need to be admitted to the hospital to get IV antibiotics or get intravenous fluids, etc. Very small percentage of those kids may have underlying congenital abnormalities in their urinary tract that make them predisposed for these kind of infections. So we have to do some workup to try to understand why these kids are having urinary tract infection, and based on this workup, a small percentage of them may require some sort of surgical treatment, either draining some sort of congenital blockage. Some of them may have like a stone that we need to remove. At some point. And we have also to address the risk factors for these urinary tract infection, the most important of which is constipation and what we call voiding dysfunction or voiding problems in children.
Okay, so let's talk about this dysfunctional voiding?
Yes.
Okay, so what is that? What exactly is that?
Voiding dysfunction or dysfunctional voiding, it means that children are not able to store urine in their bladders and empty urine in an efficient way. Sometimes this can be caused by anatomic problems or some abnormalities in the innervation going to the bladder. A lot of time we call this non-neurogenic voiding dysfunction, meaning they're anatomically normal, they have normal innervation to the bladder, but they have functional abnormality in the lower urinary tract, and because of that abnormality, they're not able to store urine in the bladder in a proper way, or they're not able to empty their bladder in an efficient way.
Okay.
This can make them predisposed to getting urine leakage during daytime or at night, and it can make them at risk of getting UTIs. And in the severe forms of voiding dysfunction, they may be at risk of kidney damage because of that, because the bladder is not emptying urine in an efficient way, and then urine may back up to the kidneys because of that, causing kidney damage.
So how do you treat that?
Most of the time it's treated with behavioral changes. So we have to educate parents and children on drinking enough water, urinating or peeing at regular intervals without holding urine. We have to teach them how to relax their pelvic floor. A lot of time we think this is done by nature. It is natural process most of the time. But we have to make sure we have the perfect setting so that kids can empty their bladder in an efficient way. Some kids, though, are not able to do that by only behavior modification. They may benefit from some medical treatment. Some of them may require pelvic floor training, so we have to refer them to like a physical therapist who teaches
physical therapy for that.
Yeah, who teaches children how to relax their pelvic floor, for example, when they go pee. And a small percentage may require surgical intervention if they have anatomic blockage, if their bladder continue to function abnormally despite using the behavioral treatment and physical therapy and medical therapy. So a lot of time it's teamwork. We work with our pelvic floor therapy if we need to. And also these kids need to treat a lot of time they have associated bowel dysfunction like constipation. So they need to be seen by the bowel specialist as well.
Okay. And we have this team, we have access to this team here at WVU Medicine Children.
We're fortunate to have access to all the facilities that we need to treat these kids appropriately. So we have bowel specialists, we have pediatric urology, we have pelvic floor therapy.
You have a large team, which is great.
Sure.
Okay, another common problem, bedwetting. How do you treat bedwetting?
Bedwetting is actually one of the commonest problems we see. Good news is in a lot of children, it improves over time. So about 15% of the kids affected with bedwetting would improve every year and become dry at some point. So we would like to assure parents a lot of time they're worried about their children if they wet their bed. Almost the big majority of these kids have normal anatomy, they have normal innervation to their bladder. So it takes some time until they can establish this link between their brain and their bladder. They're able to control their bladders when they are asleep. A lot of time treatment is focused on some of the behavioral changes that we talked about. We need to adjust their fluid intake, making sure they are well hydrated during the daytime. They reduce their fluid intake before going to bed. We'd like to, children should also try to reduce intake of salty food, a lot of caffeinated beverages, because it makes them produce a lot of urine at bed and eventually wet their bed. We have also to treat constipation if it exists. If constipation is a problem, then it limits the storage capacity of the bladder. So the bowel and bladder are very well connected. If a problem happens in the bowel side, then it affects the way the bladder functions. Some of these kids may need to be alerted. Sometimes we use what we call bedwetting alarm to help kids get up when their bladder is full and they're about to have an accident or wet their bed. Some children may benefit from some sort of medical treatment, some medication to reduce their urine production at night or improve their bladder capacity. And of course, we have to address some of the conditions that predispose for bedwetting. like constipation as well as obstructive sleep apnea. When they have large tonsils and large adenoids, these tonsils or adenoids may block their airway, and then it makes them predisposed for bedwetting.
Okay, so there's a lot of options for treatment for a very common problem.
And again, it's a very benign condition most of the time. We have to address the risk factors. We start with behavioral treatment in almost all kids. And fortunately, again, we have access to specialists in different disciplines if we need to.
Excellent. Good to know. Good to know. All right. Now, this is a condition I haven't heard of before, but we talked about this earlier. What is testicular torsion? What is this exactly?
Yeah, testicular torsion is one of the emergencies we see a lot in the field of pediatric urology. And I'd like to make sure that parents and families are aware of this condition. So, as you know, for all our body organs, they need blood supply to survive. And if the blood supply is cut at some point, these organs will have some sort of damage, or part of it will die if the blood flow is not restored in an appropriate time window. In testicular torsion, the testicle twists around its blood supply. It cuts at the blood supply.
Oh, wow.
This happens most of the time in the adolescent age group. It presents with a sudden pain in the testicle, sometimes swelling, redness in the testicles, and a lot of time associated with nausea and vomiting. It has to be diagnosed and treated promptly or in a short time frame. Otherwise, if not treated, if the blood supply to the testicle is not restored, this testicle will die. That's why we'd like to make sure all parents, families, healthcare providers are aware of that condition.
Okay, so how do you treat that?
Yeah, again, if your kid has sudden pain in their testicle, they need to be seen by a specialist immediately.
Immediately?
Yeah, within a few hours. The treatment, diagnosis is clinical. Sometimes we need to confirm the diagnosis with ultrasound, but once the diagnosis is established, they need to be taken to the OR for immediate surgery to untwist the testicle and retrieve the blood supply. We're successful doing that if they present within 6 hours of the starting their pain. The testicular salvage rate, or we're able to save the testicle almost always if they present within 6-hour window. The longer they wait, the less likely we're able to save the testicle.
Yeah, so what could happen if they don't make that window?
Yeah. Again, we do our best to make sure kids are treated in this window. Again, kids have to be aware of this, teachers, families, parents, so that when the kids have this kind of symptoms, they need to be seen by a specialist immediately. If you wait longer, the chances of losing the testicle is higher, but there are still some chances. But if you wait like for 2 days or longer time, the chances comes down to 0. So everybody should be aware of this. Kids have to be brought to the medical care quickly, as fast as possible. A lot of time, again, they're adolescents, they're shy to talk about these kind of problems. So you have to make this conversation happen between kids and their families. They have sudden testicular pain, they have to bring this up to their parents, and parents should bring the kids immediately to the ED or to be seen by a pediatric urology specialist to be treated immediately.
Okay, you mentioned at the top of the show prenatal hydronephrosis. Am I saying that right?
Prenatal hydronephrosis. So
nephrosis.
Yes.
Okay.
Prenatal meaning it's diagnosed before birth. Hydro is fluid, and nephrosis is a kidney condition.
And this is common. What is it?
Yeah. So prenatal hydronephrosis is seen in about 1 to 4% of all pregnant ladies. Is diagnosed based on the ultrasound or prenatal ultrasound. Almost all pregnant ladies get an ultrasound to scan the baby for any anomalies, usually between 16 to 20 weeks of gestation. And the commonest anomaly diagnosed on this ultrasound is actually antenatal hydronephrosis or prenatal hydronephrosis. It means that on the ultrasound, we see some fluid on the kidneys of the fetus or the baby. A lot of time it's called physiologic, meaning it does not have long-term consequences, but it needs to be followed up for a certain period of time after babies are born just to make sure it resolves or improves or goes away. About 1/3 of patients have some anatomic abnormalities in their urinary tract, and at this point they need to be seen by a pediatric urologist and then do some more testing, and some of them may be at risk of getting frequent UTIs or urinary tract infections, and a small percentage of them would require surgical correction for these anomalies. So the journey starts before birth. Some of those kids have very severe obstruction that may need to be relieved before birth, otherwise it would affect their kidney function long term.
So how do you do that?
This is offered in some certain centers of expertise. It's some kind of fetal surgery to drain their bladder. Again, very small percentage of these kids would require these kind of fetal interventions. The vast majority are born healthy, but we need to see the families before the kids are born to explain what is that and talk about follow-up, what needs to be done after birth. As I mentioned, about 2/3 is called physiologic, meaning it will improve eventually over time without requiring any surgical intervention. About 1/3 of them may be at risk of getting UTIs, which is urinary tract infection, and some of them may require surgical correction eventually.
And one more thing, pediatric robotic surgery. Why is this a big deal?
Of course, yeah. Robotic surgeries offers surgical disciplines in general a great opportunity to optimize the care they provide to their patients with great visualization, great or outstanding dexterity, so we can do the surgery in a refined way through very small incisions in the abdomen, as opposed to the standard open surgery that we're used to. The surgery, kind of robotic surgeries, were first adopted in adults, then it gained acceptance later on in children. We are fortunate to have this Pediatric Urology robotic surgery program here in West Virginia for over 10 years. We've done over 300 cases so far. You can get the same outcome, if not even better, compared to open surgery for some of the conditions we treat, through very small incisions to ensure that kids have very minimal pain after surgery. They're able to go to school quickly as possible. They're able to go back to their normal activities, and parents are not staying away from work or need to stay in the hospital for a long time. And again, better cosmesis, very small incisions that are barely visible. So we're fortunate to have this program here in West Virginia, and we can assure families that using robotic surgeries, we can provide the best outcome for some of the conditions we treat with robotic surgery, with minimal pain, shorter time to recovery, less pain medication, and shorter hospital stay. And in the recent few years, we have even transitioned to outpatient robotic surgeries.
Wow.
So even though the kids have really big surgeries, they're able to go home on the same day and probably to school in 2 or 3 days.
Okay. So before we go, what's the most important thing you want parents to know about the WVU Pediatric Urology program at WVU Medicine Children's?
Yeah, I would like to reassure family that here at WVU Medicine Children Hospital, we can treat the whole spectrum of pediatric urology conditions. We have access to all the facilities and equipments we need in open surgery, endoscopic surgery, minimally invasive surgery, including laparoscopic and robotic surgeries. We have fellowship-trained pediatric urologists. We have outstanding support from our mid-level provider and our nurses. And we are fortunate also to have kids be seen by experts from other different disciplines if they need to. We have Children's Hospital that offer the whole care for children with different conditions. We have a dedicated radiology department for kids. All the practices are done in a child-friendly fashion. We're trying our best to give the kids the state-of-the-art care in different pediatric urology conditions, and we have been ranked among the best pediatric urology programs in the nation. We have also outreach clinics, so kids can be seen for their pediatric urology conditions, not only in Morgantown, but we have outreach clinic or telemedicine clinics in Martinsburg, Parkersburg, Princeton County, and in Wheeling as well. So we can get through telemedicine, we can get connected in families in these locations without needing to travel to Morgantown, to save them time and effort and money as well.
Okay.
So they can be seen there for initial diagnosis, for their post-operative care. And we have multidisciplinary clinic when kids are being seen by multiple specialists at the same time, like the spina bifida clinic, voiding dysfunction clinic, and the pediatric stone clinic.
So you've got all the bases covered here when it comes to pediatric urology.
That's right.
Hey, thank you so much for sharing all this information. I know we covered a lot of ground, but I think we've answered a lot of questions for some parents out there. But thank you for sharing this information.
Thank you so much, Mary. I appreciate this opportunity. It's a pleasure being here.
Good to have you. That brings us to the end of this edition of Live Healthy West Virginia. If you're looking for more information on pediatric urology issues, you can always visit wvukids.com/urology. And to find the latest episode of, or all of our episodes of Live Healthy West Virginia, visit wvmetronews.com/podcast. I'm Mary Ravazio Menard, and on behalf of Dr. Ali and everyone at WVU Medicine, thanks for joining us.